A major outbreak of Cyclospora US is unfolding in the United States, and the investigation has changed rapidly. As of July 17, 2026, public health authorities have linked the largest identified cluster to shredded iceberg lettuce served at Taco Bell restaurants in 5 states: Indiana, Kentucky, Michigan, Ohio, and West Virginia. More than 1,644 illnesses have been associated with this specific outbreak. At least 94 patients have been hospitalized, although fortunately, no deaths have been reported. The FDA's traceback investigation converged on a single supplier of iceberg lettuce from Mexico. Taylor Farms de Mexico has announced that it is voluntarily removing all iceberg lettuce sourced from central Mexico from the United States market, and has informed the FDA that it intends to initiate a recall. Detailed recall information is still evolving. But this is important. The Taco Bell-associated outbreak is not necessarily the entire story. CDC is simultaneously investigating other clusters and sporadic cases across the country that may not be related to this lettuce exposure. So, what exactly is happening? What is Cyclospora? Why is it so difficult to diagnose? And what should clinicians and the public do right now? Let's go through it carefully. The current epidemiology CDC's national surveillance data provide a broader snapshot. Between May 1st and July 13th, 2026, at least 1,645 laboratory-confirmed cases of domestically acquired cyclosporiasis were reported from 34 states. Among those patients, 141 were hospitalized, and no deaths were reported. Patients ranged in age from 2 to 95 years, with a median age of 44, and 56% were female. CDC is also aware of more than 5,100 additional reports that still require analysis to determine whether they meet the definition of domestically acquired cyclosporiasis. For perspective, only 249 nationally reported cases had been identified during the comparable period in 2025. That means the confirmed count in 2026 is more than 6 times higher. And because Cyclospora is frequently not tested for, not recognized, or not reported, the true number of infections is almost certainly substantially higher. Content reference, open bracket, OAI, site, 2, close bracket, index equals 2. You may notice that the national surveillance count and the outbreak-specific count appear almost identical. These are provisional datasets updated on different dates and through different surveillance and outbreak investigation systems. They should not be added together or interpreted as perfectly synchronized numbers. The central message is that there is one very large, now epidemiologically linked, 5-state outbreak, and additional illnesses and investigations are occurring nationally. What food has been implicated? The strongest epidemiological signal is shredded iceberg lettuce served at Taco Bell restaurants. Investigators examined detailed food histories from 190 patients who reported eating at Taco Bell. Approximately 90% reported eating iceberg lettuce. FDA traceback then identified convergence on one supplier of Mexican iceberg lettuce used by the Taco Bell locations where patients had eaten. Taco Bell committed to stop using lettuce from the identified supplier, and Taylor Farms de Mexico began removing iceberg lettuce sourced from central Mexico from the U.S. market. Illness onset dates in the specific outbreak ranged from May 13th through July 13th, 2026. Because Cyclospora has a long incubation period and reporting can be delayed for weeks, additional cases may still be identified even after the implicated product is removed. The current CDC recommendation is specific. Do not eat food containing shredded iceberg lettuce from Taylor Farms de Mexico served at Taco Bell locations in Indiana, Kentucky, Michigan, Ohio, and West Virginia. This is not currently a recommendation to avoid every type of lettuce, every salad, or every Taco Bell location in the country. The investigation remains open, however, and additional restaurants, retailers, brands, or distribution channels could be identified. What is Cyclospora? Cyclospora cayetanensis is a unicellular coccidian parasite that infects the small intestine. It is not a bacterium. It is not a virus. And it does not behave like the usual causes of acute food poisoning. People become infected after ingesting food or water contaminated with infectious Cyclospora oocysts. Humans appear to be the principal host. Infected people shed immature, non-sporulated oocysts in their stool. Those oocysts are not immediately infectious. They must remain in the environment under favorable conditions for approximately 1 to 2 weeks to mature, or sporulate, before they can infect another person. That explains an important clinical and infection control point. Direct person-to-person transmission is considered unlikely. A patient with cyclosporiasis generally does not infect a household member immediately through casual contact in the same way that norovirus, Shigella, or Cryptosporidium may spread. Instead, contamination typically occurs somewhere in the food or water supply, potentially involving human fecal contamination during growing, harvesting, processing, packing, or food preparation. The precise contamination event in this outbreak has not yet been publicly established. Colon content, reference open bracket OI site colon 5, close bracket, index equals 5. Why fresh produce is frequently involved. Cyclospora outbreaks in the United States have repeatedly been associated with fresh produce. Previous outbreaks have involved leafy greens, packaged salads, cilantro, basil, raspberries, snow peas, and other fruits, vegetables, and herbs. Fresh produce creates a particular problem because it is frequently eaten raw. There is no final cooking step to kill the parasite. The complex surfaces of leafy vegetables can also make physical removal difficult. Washing produce under running water may reduce contamination, but washing cannot guarantee that every Cyclospora oocyst will be removed. Routine chemical sanitizers and disinfection procedures may also be insufficient. Cooking food to at least 158 degrees Fahrenheit or 70 degrees Celsius can kill the parasite, but cooking is obviously not practical for many salads and fresh herbs. The clinical presentation. Symptoms usually begin approximately 1 week after exposure, but the incubation period can range from about 2 days to 2 weeks or longer. The hallmark is prolonged watery diarrhea. The diarrhea may be frequent, explosive, and associated with substantial urgency. Patients commonly report anorexia, abdominal cramping, bloating, excessive gas, nausea, fatigue, and weight loss. Some patients develop vomiting, myalgias, headache, low-grade fever, or other nonspecific flu-like symptoms. The fatigue can be striking and may persist even after the diarrhea begins to improve. Unlike many bacterial foodborne illnesses, bloody diarrhea and high fever are not the typical presentation. Without treatment, symptoms may continue for several weeks or longer. A classic feature is a remitting and relapsing course. The patient starts to improve, believes the illness is resolving, and then the watery diarrhea returns. Reported complications include dehydration, electrolyte abnormalities, malabsorption, cholecystitis, and reactive arthritis. Immunocompromised patients, particularly those with advanced HIV or significant T-cell dysfunction, may experience more prolonged, severe, or recurrent disease. Who should clinicians test? During the current outbreak, clinicians should consider Cyclospora in any patient with prolonged or relapsing watery diarrhea, particularly when symptoms have lasted several days and routine testing has been unrevealing. Do not exclude Cyclospora simply because the patient has not traveled internationally. Historically, many clinicians associated cyclosporiasis with travel to tropical or subtropical regions. But the current cases were domestically acquired, meaning patients became infected after eating food in the United States and reported no international travel during the preceding 14 days. Ask specifically about food consumed during the 2 weeks before symptom onset. That history should include restaurant meals, fast food, salads, shredded lettuce, fresh herbs, berries, raw vegetables, packaged produce, catered events, and whether other people who shared the meal became ill. For this outbreak, specifically ask whether the patient ate at Taco Bell in Indiana, Kentucky, Michigan, Ohio, or West Virginia, and whether the meal contained shredded iceberg lettuce. The diagnostic trap. Here is probably the most important message for clinicians. You must specifically request testing for Cyclospora. A routine ova and parasite examination may not reliably detect it, and not every commercial gastrointestinal multiplex PCR panel includes Cyclospora. Do not assume that GI-PCR negative means Cyclospora has been excluded. Look at the exact targets included on your institution's panel. When molecular testing is available, stool PCR is generally the most practical and sensitive approach. Microscopic diagnosis is also possible. Cyclospora oocysts measure approximately 8 to 10 micrometers and may be detected using concentration techniques followed by modified acid-fast staining, modified hot safranin staining, or ultraviolet fluorescence microscopy. The oocysts are variably acid-fast. Some stain pink or red, while others may remain nearly unstained in the same specimen. They also autofluorescence blue or green under ultraviolet illumination. Another diagnostic challenge is intermittent, low-level shedding. Even a symptomatic patient with profuse diarrhea may have relatively few oocysts in an individual specimen. Therefore, one negative stool test does not completely exclude the diagnosis. When clinical suspicion remains high, several specimens collected on different days may be necessary. CDC laboratory guidance notes that 3 or more specimens collected at 2 or 3-day intervals may sometimes be required. Treatment. The treatment of choice is trimethoprim sulfamethoxazole. For an immunocompetent adult, the standard CDC regimen is 1 double-strength tablet containing trimethoprim 160 mg and sulfamethoxazole 800 mg, taken orally twice daily for 7 to 10 days. For children 2 months through 18 years of age, the recommended total daily dosage is trimethoprim 8 to 10 mg per kilogram and sulfamethoxazole 40 to 50 mg per kilogram, divided into 2 daily doses for 7 to 10 days. Patients with HIV or other significant immunocompromising conditions may require a longer treatment course, depending on their clinical response and immune status. Supportive care is also important. Assess hydration, renal function, and electrolytes in patients with severe or prolonged diarrhea, particularly older adults, young children, and patients taking diuretics or other medications that increase the risk of volume depletion. What about patients with sulfonamide allergies? Unfortunately, there is no consistently effective alternative to TMP-SMX. Metronidazole does not reliably treat cyclospora. Neither do tinidazole, albendazole, doxycycline, azithromycin, or trimethoprim alone. Ciprofloxacin demonstrated modest activity in one small study involving people with HIV, but extensive clinical experience suggests that it is substantially less reliable and often ineffective. For a patient with a reported sulfonamide allergy, the first step is to determine whether the allergy represents a true, severe hypersensitivity reaction or an intolerance. Depending on illness severity and the nature of the prior reaction, options may include supportive care, consultation with allergy and infectious diseases specialists, or carefully supervised TMP-SMX desensitization in a selected patient. Desensitization should not be attempted in someone with a history of a severe, life-threatening cutaneous reaction, such as Stevens-Johnson syndrome or toxic epidermal necrolysis. TMP-SMX use during pregnancy requires an individualized risk-benefit assessment. Particular caution is warranted near-term because of the theoretical risk of neonatal hyperbilirubinemia and kernicterus. Treatment decisions in pregnancy should be coordinated with obstetrics and infectious diseases. Why Cyclospora outbreaks are so difficult to investigate. Cyclospora is almost designed to frustrate outbreak investigators. First, the incubation period is long. Patients must remember foods they consumed 1 or 2 weeks before becoming ill. Second, many patients wait several days before seeking medical care. Third, clinicians may initially diagnose viral gastroenteritis or order a stool panel that does not test for Cyclospora. Fourth, laboratory confirmation and reporting create additional delays. CDC estimates that there may be approximately a 6-week lag between illness onset and national reporting. By the time investigators identify a cluster, the implicated produce may already have been eaten, discarded, or passed through the supply chain. And unlike Salmonella, Listeria, or E. coli, investigators do not yet have the same broadly available whole genome sequencing infrastructure for matching Cyclospora from patients and foods. Public health agencies use targeted multi-locus genotyping, epidemiological interviews, purchase records, distributor information, and traceback investigations, but the process is slower and less precise. That is why investigators may identify an epidemiological link before the parasite is actually recovered from the implicated food. What should the public do now? Do not panic and do not stop eating all fresh produce. Follow the specific outbreak advisory. Avoid shredded iceberg lettuce from Taylor Farms de Mexico served at Taco Bell locations in Indiana, Kentucky, Michigan, Ohio, and West Virginia until public health authorities say the risk has passed. Wash hands before and after handling food. Rinse fresh fruits and vegetables thoroughly under running water before cutting, eating, or cooking them. Refrigerate cut produce promptly and avoid cross-contamination with unwashed produce or potentially contaminated surfaces. But remember, washing reduces risk. It does not guarantee that Cyclospora has been eliminated. Seek medical attention if you develop prolonged watery diarrhea, significant weakness, inability to maintain hydration, reduced urine output, dizziness, severe abdominal pain, or symptoms that improve and then repeatedly return. Tell your healthcare provider about any Taco Bell exposure and specifically ask whether testing for Cyclospora is appropriate. Colon content. Reference open bracket OAI site :14, close bracket, index equals 14. What should clinicians do now? My practical recommendations are straightforward. First, add Cyclospora to the differential diagnosis of prolonged watery diarrhea, even without international travel. Second, verify that your gastrointestinal PCR panel actually includes Cyclospora. If it does not, order a Cyclospora-specific PCR or specifically request appropriate parasitologic testing. Third, do not abandon the diagnosis after one negative specimen when the clinical suspicion remains high. Fourth, obtain a detailed 14-day food history, not merely a generic question about sick contacts or travel. Fifth, treat confirmed symptomatic infection with TMPS-MX unless a genuine contraindication exists. And finally, report confirmed cases promptly to the local or state health department. Cyclosporiasis is nationally notifiable, and rapid reporting may help investigators identify additional clusters and remove contaminated food before more people become ill. Final perspective. The key lesson from this outbreak is that prolonged watery diarrhea during the summer is not always viral gastroenteritis, irritable bowel syndrome, or a medication side effect. Cyclospora can be missed because clinicians do not request the test, laboratories do not automatically perform it, and patients may have no travel history. The current evidence points strongly toward shredded iceberg lettuce served at Taco Bell restaurants in 5 states, traced to a supplier using lettuce from central Mexico. But the broader national investigation continues, and additional unrelated clusters may exist. So remember 3 things. Think about Cyclospora, order the correct test, and ask exactly what your patient ate during the 2 weeks before the diarrhea began. Because in this outbreak, recognizing the pattern may not only lead to the correct treatment, it may help public health officials find the next contaminated food before thousands more people are exposed.